Good evening, everyone. A very warm welcome to all our esteemed speakers and to everyone joining us live. I am Dr. Mayank Tevatia from Voice of Healthcare team, and it's my absolute pleasure to moderate today's expert panel discussion on navigating migraine with experts, not assumptions, from awareness to action, redefining migraine care. Today's session is organized by Voice of Healthcare, powered by Amneal Healthcare, aimed at bridging knowledge gaps around migraine through expert led discussions. We sincerely thank Amneal Healthcare for their support in enabling this important conversation. Migraine continues to be one of the most common and yet one of the most misunderstood neurological disorders of our time. It's estimated to affect between 14 and 20% of India's population, nearly 200 million people worldwide, and its impact goes far beyond the headache itself, touching physical health, emotional well being, and productivity, and overall quality of life. And yet, despite how widespread it is, migraine remains significantly underdiagnosed and underrated, held back by misconceptions, delayed recognition of symptoms, and limited awareness of treatment options available today. That's exactly what we are here to change this evening. Over the next 60 minutes, we'll move through four thematic rounds with our panel of eminent neurologists, from recognizing the true impact of migraine to and finally to the public health and policy shifts we need to see. And if time persists, we'll close with a quick rapid fire round. Let me introduce you to today's panel. Dr. Praveen Gupta, Chairman, Neurology, Marengo Asia International Institute of Neuro and Spine, Gurugram.
Thank you for having me.
Thank you so much, Doctor. Dr. Manoj Khanal, Director and Head Neurology, Mac Super Speciality Hospital, Shalimar, Bagh, Delhi.
Thank you.
Thank you so much, sir. Dr. Birinder Singh Paul, Professor, Department of Neurology, Dayanand Medical College and Hospital, Ludhiana.
Hello, everyone. Thank you for the opportunity. Thank you.
Thank you so much, sir. Dr. Amit Shankar Singh, Senior Consultant Neurology, Fortis Mohali.
Good evening, everyone. Thank you.
Thank you so much, sir. Welcome to all of you. Thank you so much for being here this evening. Let's get straight into it. We'll begin with the round one. Beyond the pain, recognizing the true impact of migraine. Let's start with Dr. Gupta. Despite growing awareness, sir, microconceptions about migraine continue to persist. Which myths do you believe are the biggest obstacles to timely diagnosis and appropriate treatment?
See, the problem with migraine is that it has been a long-standing disorder, and the myths have been stood the test of time over years. People tend to believe lay persons and lay accounts rather than medical opinion because it is convenient and it is more accustomed to them. That is why myths like migraine cannot be cured, so it should not be treated. Migraine is best treated by painkillers that you can pop by asking your chemist. Migraine is a disorder which, if you treat it, it will cause you weight gain. Migraine medicines will not suit you. So there are multiple things about migraine, including the disease and the treatment, that are inherent barriers to proper treatment. So, and a lot of people only recognize migraine as half side headache. People don't realize that migraine can happen on the back of head, it can happen on both sides of head, and it can have many varied presentations, which basically means that migraine, if it can come out of the clutches of various myths, it can make lives of many people happier and simpler.
That's such an important point, sir. The myths really do seem to be half the battle. Coming to Dr. Khanal, so building on that, although migraine affects millions of people in India, many individuals remain undiagnosed or inadequately treated. What factors you think are contributing to this significant care gap?
Yes, very pertinent question in India, particularly where there is low public awareness, social stigma, shortage of specialists, and frequent misdiagnosis. The lack of recognition because people often treat migraine as a normal headache and do not seek medical help. They feel that it is a simple headache, it will go off with time. Social stigma means people even hide the pain or feel embarrassed. Particularly in rural areas, you will see a lot of ladies, they suffer from this for several years because of lack of education and plus lot of people say that this is because of daily stress and long work hours, and they ignore the symptoms until they become severe. Once they become severe, they reach the doctor, and there is even shortage of experts. Very few trained neurologists or headache specialists, or particularly those specialists who are trained in treating headache and migraine, are lacking in India, and most of them are in the large cities. Next is the misdiagnosis. The GPs, the general practitioners, they mistake migraine for sinus problems, for eye strain or tension type of headache. And people, most of them, they rely too much on simple painkillers. People often use this over the counter drugs instead of proper medical care. So because of all these several factors, you will see in a lot of places there is misdiagnosis of migraine, and migraine is not caught initially.
Thank you so much, Doctor. A care gap that size clearly needs more than one solution. Coming to Dr. Paul. So, from a clinical recognition standpoint, beyond recurrent headaches, what early clinical signs or patient characteristics should healthcare professional and primary care physicians recognize to enable earlier diagnosis?
Thank you. As you have already mentioned that migraine is one of a common disorder, and if we see in our practice, OPD practice or indoor practice, 90% of the neurological, you can say, admissions or presentations, and 60% of other specialty presentation will include headache as one of a symptom or a sign. So it is very important. There are certain background subset of persons in which we always think this is not migraine. That for the general public, they should know any extremes of age. A child less than 8 years of age or an elderly individual more than 45 years of age. You should think of this could be a red flag, or those who have been like you like a hyper, you can say coagulable state. The blood is very thick, like pregnancy, immediately post delivery or post cesarean sections, and other those who are taking some form of treatment for like steroids, immunosuppressive therapy, post renal transplant, or which have hepatitis B and C. In them, if headache is a presenting symptom, we should think that something going wrong. Or those who are taking blood thinners, or there is a history of any head injury even prior 3 months also. So these are set of cases which we have to be very particular. And one important thing everybody should understand, that you can have two diseases in the same person also. If there is a change in the character of headache in a known migraine, and that character of headache has changed, the intensity and frequency have increased, plus it is not responding to the usual painkiller which were they were taking earlier, then this is again a red flag. Plus, when you consult a physician, the physician can detect some signs like you have visual problem, double vision is there, visual blurring is there, you have balance problem, you have problem in, you can say, your memory is going down, or you are waking up with the headache at the night time, then it is a time, high time, that this is probably may not be migraine. So you should be to a physician or whichever physician you are consulting, and then these are the few of the instances where we have to do the brain imaging or other investigation to prove the diagnosis or disprove that this is not a, or to prove that it's only migraine. Sometimes migraine is even, sometimes we make a diagnosis of exclusion of the other disorders. So we should not ignore, and all headache is not tension headache, all headache is not migraine headache. We should also consider the other possibilities. Then only we will be able to, because if we miss, it may be a catastrophic in some of the instances also. Thank you.
Thank you so much, sir. That's incredibly useful, especially for the primary care physicians watching today. And to close out this round, I would like to ask my last question to Dr. Singh. Sir, many patients spend years relying on self medications before consulting a specialist. What are the key behavioral and healthcare related barriers responsible for these delays?
Yeah, very pertinent question. And we have seen many patients, they take self medication, over the counter medication before consulting the specialist. And it has two parts. One is behavioral barrier, and other is healthcare related behavior barrier. So regarding the behavioral barrier, if I would say that many patients, especially ladies, they think that headache is a normal thing in one's life, and they tolerate it though it affect their productivity, and whenever they find it difficult, they take pills. and that are very easily available as over the counter medication, and even they are advertised over the counter medications are also advertised many times, and they are very easily available in our country. So that's why they take self medication and they don't consult the specialist. But many times if you take medication regularly and in a large amount in high frequency, then you will develop medication overuse headache. So these are the side effect of self medication. So this should not be done in patient with migraine. Along with that, as many patients have no physical disability visible in cases of headache, like in stroke, in seizures, they see physical ability. In Parkinson's, they see abnormal movements. In strokes, they see abnormal the weakness on the body. In headache, they only feel, and it's all in the brain. So that's why they don't bother a lot before consulting a specialist, and they only bother when it is intractable. And so these are the behavioral barriers because of which patients are self-medicating themselves before consulting the specialist. Regarding healthcare related barriers, if I say the self-medication is due to lack of awareness about the disease, and for that we are also somehow responsible. We should make the general public more aware of the disease and what are the side effects of taking self-medication, what is medication overuse headache. And one thing is also non-availability of the specialist in many places where the patient cannot go to the specialist and they rely on the self-medication. So these are the reason why many of the patients are self-medicating themselves.
Thank you so much, Dr. Singh. Years of self medication is a sobering statistic, and it's exactly why a session like this one matters. That gives us a real honest picture of where things stand today. Let's now move to the science. Coming to our round two, which is the evolving science of migraine, innovations in diagnosis and treatment. I would like to come back to Dr. Gupta. So let's start with you. CGRP targeted therapies are redefining preventive migraine treatment. Which patients are likely to benefit the most, and how are these therapies changing clinical practice today?
See, there are two things. CGRP therapies are targeted therapies and more precise therapies for migraine treatments as compared to the usual preventives or painkillers used to treat migraine. When we look at the scientific data, the CGRP therapies look like they are a boon to migraine patients, and the migraine will disappear from people's life. But that does not happen in clinical practice. Why? Because migraine is not one thing. Migraine is mixed up with many things, which includes biological tendency to get headache, hormonal changes, lifestyle, sleep, food, depression, anxiety, expectations in life. So, unlike the way trials say it in India, the CGRP therapies benefit has been moderate. Okay. And not everybody benefits from that therapy, or everybody is not happy with that therapy, because these therapies come with a very large amount of cost burden. And like somebody said, stroke and Parkinson's are visible manifest disorders that cause disability. Since migraine causes just pain and no disability, a lot of people are not willing in India to spend out of pocket for CGRP therapies. Okay. Which basically means that, but for people who are not responding to standard therapies and people who continue to get headaches despite standard prophylactic therapies, who are getting into chronic migraine, or who are having intolerable side effects with the usual therapies, or they want to choose therapy which is safer, which is effective, CGRP therapies are possibly the most relevant therapies in today's time.
Thank you so much. So that's a real shift in how preventive care is being approached nowadays. Coming to Dr. Khanal, sir, as migraine presents differently in every patient, how close are we to delivering truly personalized treatment based on the disease patterns, triggers, and patient characteristics?
Yes, a very important question. As rightly said by Dr. Praveen, we are moving closer to personalized migraine treatment through targeted therapies like CGRP inhibitors and the use of digital tracking apps. The current progress in tailored therapy, the most common is the targeted therapies, that is the CGRP and the GPANs. This allows the doctor for an acute or preventive options based on specific headache mechanisms rather than the old trial and error method. What we used to do is to give painkillers, we used to use other drugs. Now it is the definite treatment that is being provided. The second mode of therapy is by digital tracking like smartphone apps. We can map the real time data of the episodic pain curves and the attack durations, and based on that the physicians or the headache specialist, he can adjust the timelines, and the abortive medication like the gpants and the cgrp, they can be used, and it can be choice of patient to match a specific unique pattern. Third is the we can do some comorbidity matching, like overlapping conditions. The patient may have depression, they may have sleep disorders, high bmi, so these also guides in the patient selection process. But we have several barriers. What are those barriers? The barriers in treatment of targeted therapies is the complex genetics. There is no elusive, no biomarkers are not available like that in other diseases. We have biomarkers in this, in migraine, like blood or imaging biomarkers are not available. And the most important is the trigger variability. In one patient may have one trigger, other may have another trigger. So these physiological triggers like barometric pressure or hormonal shifts, they are largely unpredictable and they are very hard to target pharmacologically. So these are the several drawbacks that despite targeted therapies, we are lacking behind.
Thank you so much, sir. Personalized medicine really does feel like the direction everything is heading. Coming to Dr. Paul, sir, how advances in neuroimaging, biomarkers, and digital health technologies are improving diagnostic accuracy and helping clinicians monitor treatment outcomes more effectively?
Thank you. So just it has two parts. One is the imaging part, other is the what doc previously also said, biomarker. So if we take imaging into account, initially if we go back to the history said that migraine is a vascular disorder. So we used to treat with beta blockers, calcium channel blockers. These are the drugs. Now with the advancement in the neuroimaging technique, which we call as a functional imaging technique, availability of the PET scan, high you can say camera resolution MRI like 7 Tesla MRI, which is being now researched and being used. It is available in India, where you can actually target the pathophysiology of migraine. By this newer modalities, or you can say research protocols, we are able to now target that the basic culprit is the activation of fifth nerve nucleus. So once we know the pathophysiology of any disease, so we can make a therapy which will target directly the pathophysiology, leaving aside the economic part. So once we are targeting the pathophysiology, so automatically the side effects will be very less of that drug, will be as compared to the other drugs, and the you can say response will be much higher as compared to the other drugs. One part. Secondly, even this neuroimaging sometimes help us when we are in a dilemma to differentiate actually migraine has resulted in brain changes of the white matter or gray matter, or it is something which is mimicking but behaving like a migraine. I must quote you, there is a one disorder in which we call as a cadassil disorder, in which you always start, this is a catastrophic brain blockage, you can say artery blockage disorder, which usually starts with the migrainous headache. If we have the facility of advanced imaging at the right at the very beginning, we can differentiate between the two types, because the treatment of two is entirely different. Coming to the second biomarker, I think it is the what we call as a change in the practice of neurology when a biomarker like protein, which we call as a CGRP, now which you have asked the question, was accidentally and was proven that it was interictal, in between the headache period, it was elevated in those who have migrainous headache. So both in the serum as well as in the CSF. So this availability of this peptide has led to revolutionize the treatment of the migraine. So, and also sometimes, or not in a usual practice, but in research, it is now being used left and right to differentiate from other disorders. And even this marker is being used to target the efficacy of the drugs or efficacy of the treatment part is there. So So this is what, and now there are so many newer peptides which are coming, and they will be the future target because you have to reduce that peptide to improve the migraine. I have seen so many patients who even say that we want to commit suicide because of migraine, please treat us. So if we are able to develop this targeted treatment, we will be giving them more comfortable life, the quality of life will be more, their economic burden will be less, their need for hospitalization will be low. And now in Punjab we are facing a problem of using tramadol, which is a, you can say, narcotic drug for management of migraine, which is easily available. So this will all be prevented if we move ahead. And I think migraine is a not a even a single disorder, it is a syndromic disorder. So thank you for this. You have panel discussion you have arranged by this medium, as already pointed by our stream speaker also, that this should be message should go to the public that there are so much newer in migraine, and migraine is another disorder which can be managed by using the over counter drugs available at your local part. Thank you.
Thank you so much, sir. It's our pleasure to raise this awareness. And now, Dr. Singh, to you. To round this off, sir, beyond medications, which lifestyle modifications and evidence based non pharmacological approaches have shown the greatest benefit in reducing migraine frequency and also in improving patient outcomes, sir?
Yeah, thanks for the question. Actually, as other speakers have also said, that migraine is not, it's just not a pharmacological disorder. Migraine is a disorder, I would say, is a lifestyle disorder. And many times, if we intervene in the lifestyle of the patient can be better. So if we talk about the lifestyle modification, so healthy lifestyle is the crux or essence of migraine management, and many times that's the sufficient only for the management of the patient. And because what migraine is actually a disorder where there is overstimulation of the sensory part of the pain in the brain, which is through the brainstem and the trigeminal nerve, and there are many triggers to those things. And if we do the lifestyle modification, these triggers will be subsided. And if we talk about the important lifestyle modification, the important ones are proper sleep, timely going to bed and getting up on time. A proper time of sleep is also important. You should take 6 to 8 hours sleep, and time go to the sleep at time, proper time. A circadian rhythm should be there. Dietary habits like non-spicy, non-oily food, and at times a timely eating is also important. You should not skip your breakfast. So timely breakfast, lunch and dinner, because many times these are the triggers. So skipping food, fasting, all these are the triggers. So if you avoid these things, then also you will prevent the headaches. Exercise and yoga meditation relieves stress, which is also an important trigger. So these lifestyles will help. Basically, by lifestyle, we need to halt the overstimulated sensory system of the brain, which is the main responsible for the migraine. So this is how lifestyle modification helps in the management of the migraine. And the second part of your question is evidence-based non-pharmacological approaches for the management. So obviously, first is the lifestyle modification, which can be easily done, as I have told. The others are like sleep hygiene with circadian optimization, yoga relaxation techniques, cognitive behavioral therapy, which prevent the stress, and therefore it helps in the management of migraine. Now there is a non-pharmacological neuromodulation technique is also there. Neuromodulation devices are there. Transmagnetic stimulations are there, where pharmacological involvement is not there. So you do not to take a pill. You have to wear a device, and it can be controlled by the app. And during the attacks, and for the prevention of the headache also, you can use that. And other therapies are like trigger avoidance therapy. So triggers are the things that trigger a headache, and it should be avoided. And there are trigger avoidance therapy which can be done digitally as well. And in the diet, you can include magnesium and riboflavin, which are now considered as the preventive chemicals, preventive food supplements for the patient. So this is how non-pharmacologically also, without taking pills, you can manage your migraine and treat it. So this is the answer of your question, very pertinent question.
Thank you so much, sir. It just gives us a good reminder that treatment isn't just about the prescription pad. Now, before we move to our next round, some people have been commenting, some of our viewers have been commenting. Let's just go with the comment and yeah. Rahul, can I just please see the comment, please? There's, yes. So one of our viewers have commented that can migraine change over time? Uh, Anyone who can just is willing to answer that.
So it's natural for migraine to change over time. Migraine starts as an episodic headache, and sometimes when the headache starts, the episodes are far and few in between, and they happen at times when you miss your sleep or you miss your food or you are in a function where noise is very loud or you travel. So this is what people sometimes mistake as a normal headache, but there is nothing known as normal headache. And then the frequency of migraine continues to increase, and people continue to take more painkillers rather than resorting to preventive medication, which means they are suppressing their migraine but not treating their migraine. Over a period of time, this same migraine translates from an episodic migraine characterized by nausea, vomiting, pulsating headache into a dull ache which lasts for days together, which is we call as chronic migraine. So when migraine transforms like this, it can be called transformed migraine also. So migraine can only not only change its frequency and type of pain, migraine can also change the location of pain. There are people who have pain in one area, the location of the pain can change. So as the life progresses, migraine will undergo many changes, and whenever, however, there is a significant or sudden change in a patient who has migraine headache of one type and the headache is unusual, different, or there is a new pattern, you should always think of other disorders also. Because it is true that a migraine patient has migraine and we call him a known case of migraine, but migraine patients can have other serious headache disorders also or different headache disorders also. And sometimes two headache disorders can occur in the same person. And if we do not give credence to that, we may end up just treating one headache disorder, which may not be sufficient to treat that patient. So it is important for the clinicians to recognize the changes, to change their treatment along with the changes. And there are multiple therapies for different types of migraines, which can be used appropriately for better treatment.
Second, I
Thank you so
wanted
much.
to add to Dr. Praveen that even if the migraine can change, but even we have seen that those drugs which they used to get relief with the treatment, the which we call as a acute symptomatic drugs, and they also change over time. And in spite of taking all the precautions, all the biofeedback treatment form, preventive, still sometimes these drugs become unresponsive over the time. So this we should
Not,
also understand, not only the
not
character but pharmacological treatment also sometimes become infected. Then also don't have you have to panic. You have to be patient. You have to look whether you are missing or there is something trigger which is going on, so that it can be taken, because it is a multidisciplinary approach. So this is what I wanted to add to Dr. Praveen. Thank you.
Thank you so much, sir. Thank you so much for making our viewers and us understand about it a little bit more. Now coming to round three, which is empowering patients, the next chapter in migraine care. Coming back to Dr. Gupta, sir, in your experience, how does patient education influence treatment adherence, self-management, and the reduction of stigma associated with the migraine?
see, we began this session with myths about migraine. So, and we realized that the myths about migraine are the largest barrier to effective migraine treatment. And we all know as neurologists that migraine treatment in today's date is a very effective form of treatment. So, patient education about lifestyle, trigger factors, headache diaries, understanding how their headache shapes up, what are the differences, are very, very important parts of headache treatments. If a doctor just prescribes prophylactic or acute medicine to a migraine patient, I would think he has failed in his duty, because it is equally important to educate the patient on what is causing him migraine, how the migraine will get worse, what are the things that he can do in his life to make his migraine better, how a headache diary can help him, what is the timing of the painkiller to be taken, because we all know that if you take the same drug at 15 minutes post migraine and at 3 hours post migraine, the effect is entirely different. The What are the prophylactic treatments available, what are their side effects, what are their impacts. So all this knowledge is very important in allowing patients to make informed treatment choices and managing their migraine better.
Thank you so much, sir. Education really does seem to be the heart of everything that we have discussed today. Moving to Dr. Khanal, sir, with wearable devices and digital health platforms becoming increasingly accessible, how can these technology empower patients to better understand and manage their migraine patterns?
Am I audible?
Yes, sir.
Yeah. So after a good discussion, see, when the modern era has arisen, we have to also feel that modern era. So by the help of these devices, what we can do, we can track the triggers, we can monitor the real time biofeedback and provide the predictive insights. There are several tools now available, like the smart wearables, the digital digitags. All those tools are available nowadays, and with the help of those tools, we can record all those recordings, whatever is available. It will help also to know about the other things, like tracking the triggers, like automatic locks, record the sleep, steps, daily habits. All those things are nowadays AI driven. So by the help of this, there are several environmental sensors also are available, which can detect the barometric pressure, weather, light exposure. Their symptom diaries are available. Headache diary, in our institute we have the headache diary, in which we note everything. We discuss with the patient about 5-10 minutes, tell them that you have to note this. So this helps in giving the abortive treatment, the symptomatic therapy, the pain levels, the aura types, and the acute medication. Now there is also the role of biofeedback and stress management, which includes tracking the heart rate, variability, relaxation prompts for the breathing exercises, sleep analysis to measure the sleep quality, and the sleep hygiene is very important. So the sleep quality and the duration, there can be predictive insights, so that you can have trend reports. Later on, you can generate the PDF summaries, so that during the visit to the neurologist, you can maintain a proper headache diary. Along that, we can show to the neurologist that how it would predict your high risk attack days, using the combined the biometric and environmental data. So in this era of AI, we can use, there are several tools by which we can keep down, we can have a headache diary. Along with that, several smart watches are available, which can be used.
Thank you so much, Dr. Khanal. It's exciting to think of patients as active participants in their own care. Now, before jumping up to our next question, let's just answer and check one of our viewers' comment again. Yes, so we have one of our viewers have asked this question, that what are the warning signs or red flags that mean my brother should see a doctor immediately instead of waiting for a regular checkup?
Yeah,
So,
so there
please.
are red flags, and in any case of headache, we need to identify these red flags, because we have to distinguish between primary headache and secondary headache. We should know the concept of secondary headache. The primary headaches are like migraine, tension type of headache, cluster headaches, other headaches. But the secondary headaches, though they are uncommon, they are only 3 to 5% only, but they are life threatening. So early diagnosis is very important in these cases, and we need to get an imaging. So we need to remember these red flags, and we can easily remember these red flag signs by a mnemonic SNOOP 4. Okay, and P is many, SNO 4 or 10, but S stand for systemic signs or disorder, like patient is having fever, other systemic disorders, neurologic symptoms like weakness, seizures, new onset. O stand for new onset, or another O stand for onset as thunderclap presentation, and P stand for pulsatile tinnitus, positional provocation, means changing of a headache with position precipitated by exercise, or visual symptoms like because of the papilledema. So these are few red flag signs where we need to get an urgent imaging, preferably an MRI, and we have to rule out three things. Again, a mnemonic PIN. P for penny pressure abnormalities, I for any infection, and N for any neoplastic disorders. So if these red flags are there, the patient may have a secondary headache because of any of the reason. Secondary headache can be because of any reason. It can be because of malignancy, cancer, it can be because of infection, because of metabolic disorder, any systemic disorder. So if these are there, then we need to get an imaging and we need to be careful. It should be like alarm to the patient, and he should visit immediately a specialist and get an imaging urgently.
Thank you so much, sir, for giving us an overview and our viewers an overview on such an important pre-symptom things when we come to migraine. Now, moving forward with our questions, I would like to come and ask Dr. Paul. Sir, migraine frequently coexists with anxiety, depression, and sleep disorders. Why is a multidisciplinary approach, including mental health support, essential for comprehensive migraine care?
Thank you. If we look at the scientific basis, there this depression, anxiety also share the same neurotransmitter, that is the serotonin, which is involved in migraine also and the depression part. This is the scientific part. But if we look back into the patient history, into the symptoms, that this even presence of any disorder which is long standing, as we all our eminent speakers said, that is a chronic disorder, so that will harbor some sort of anxiety and depression, specifically when we are discussing the red flag. So it is at the back of your mind, am I dealing with something wrong, very serious disorder? Sometimes we are unable to convince them, we have to get the MRI to prove that this is nothing else, just a migraine. So if anxiety creeps in, it will set a vicious circle, that you will sleep less, there will be more migraine days, and then it will further trigger lack of treatment, inability to respond to the treatment, so they will trigger more anxiety. And sleeplessness is a very strong trigger for migraine. Sleeplessness due to anything like depression, anxiety, even migraine. If you see the disability, there is a one score in which you assess the sleep pattern also. And we have recently published a paper in which the if there is something wrong with the sleep, your migraine gets worse. And so they go hand in hand. If you want to treat migraine as an isolated disorder, so you will not get the results, as everybody has emphasized. So it is a multidisciplinary approach, and sometimes we have to select a drugs which will be effective for both anxiety as well as for migraine also. So now there are certain sort of drugs are there. If you have a comorbid personality of anxiety, depression, sleep, we can pick up a drug which will act on the one drug will be affecting all the three things together. So this will save the cost, this will save the side effects, and it will improve the compliance, and it will also improve the migraine part also. In addition, recently we have another paper from our institute of use of CBT, that means behavior therapy in those with migraine. We have two sets of arm in which one were given CBT, other was were not given, and those arm in which we have given CBT, there is marked reduction in their headache days. Also, there is reduction in the use of acute symptomatic treatment, that is painkillers. Plus, it has improved their quality of life, it has improved their work efficiency, and also it has improved their confidence of continuing the treatment, because the compliance which we call it also depends upon how much response you are getting. As Dr. Shankar has also said, that there are now studies which say that use of yoga, use of, you can say, meditation. But now this paper from our institute reinforces that if you do that, it might be possible that we can even to some extent cure this culprit of, you can call it, severe headache. Because those who have headache now, they are just mad on it. I am gone, doctor. My 4 days of work in the office is gone. Even a female with household activities are unable to take care. So I think this is a very important forum, and it has discussed very pertinent points which will help our viewers to understand and to seek treatment regarding the migraine part. Thank you.
Thank you so much, sir. That's such an important reminder that migraine care can't exist in a silo. Now, coming to the Singh. So, looking ahead, which emerging innovations in diagnostic, therapeutic, or digital medicine do you believe will have the greatest impact on migraine care over the next 5 years?
Yeah, very important question, and I think it has two part. You have asked about emerging innovation in diagnostic, therapeutics, as well as digital medicine, and all three are important. I think Dr. Praveen and Dr. Paul has already spoken a lot about this, but let me again. So regarding the diagnostics, so actually, the diagnosis of migraine is purely clinical, and we have a criteria. So for the diagnosis of migraine, any diagnostic is not required, and I think it will not be required in future also. So let me reiterate. So the for the diagnosis of migraine, you need headaches, moderate to severe in intensity, unilateral or holocranial, with the pulsating quality or throbbing quality, with associated photophobia, that is problem with the light, phonophobia, problem with the sounds, and sometimes nausea and vomiting. So this is the how to diagnose migraine. But if we talk about the advanced diagnostics, so we need to we need to have proper diagnostic to rule out any secondary headache. So if a patient with migraine is there, we need to see red flags. Like very close mimic of migraine is IIH, idiopathic intracranial hypertension, which I have seen in my clinical practice. Sometimes we miss IIH, and sometimes it mimics migraine. So for that, advancement in imaging will help, where we can see the pressure changes in the brain and eye, uh, and differentiate it from the migraine. Along with that, if we talk about the next 5 years, we may have a method or tool to measure CGRP, which is very important for the migraine. And in the ictal phase, during the episode of migraine, CGRP levels were found to be high. It is still in the research process that the CGRP levels are used, but it can be later used to differentiate migraine from other disorders. Along with that, how to measure cortical spreading depression, which is an important part of migraine with aura. So measuring this cortical spreading depression is also possible, may be possible in future in the next 5 years. And as Dr. Birinder Paul has said, functional, and Dr. Manoj also, the functional imaging which can be used to differentiate migraine with other disorders, in which the metabolic active zones in the migraine we can find out. So these are all possible diagnostics which we may see in future. Regarding therapeutics, I would say this era is an era of new drugs and innovations in migraine, following the knowledge of pathophysiology of migraine and knowing more about the chemicals that are involved during the pain process of the migraine, during the pain state of the migraine, like CGRP, substance P, cyclic adenylase. So against these chemicals, we are finding new drugs now, like CGRP antagonist and many other drugs. So blocking these pathway, we are getting good results. But these drugs are used in cases where severe migraine is there, where other drugs are failed, and where no other choices are there because they are costly and they are still in the research. So someday may we feel fine in therapeutics drugs, very effective, which may cure migraine, which may abort the headache, and by using as a preventive drug, which may cure migraine as well, and less costly. So these are the very good opportunities regarding the therapeutics. And with new neuromodulation techniques, also this opened new and many opportunities in the migraine treatment. Regarding digital medicine, the third part of your question, digital medicine is also growing. And without using digital medicine in migraine, I think utility is not complete. Making headache digital diaries, trigger monitoring, alarm setting for sleep, and digital consultations with the specialist is also an important aspect that we see in future, that is still it's growing and we see in future. So this is how diagnostic and therapeutic and digital medicine will change over next 5 years.
Thank you so much, Dr. Singh. It sounds like the next 5 years hold a great deal of promise when it comes to migraine. Now, let's turn to the bigger picture and let's move to round four, which is advancing equitable migraine care through public health and policy. Uh, yeah, Dr. Gupta, I think, is having some technical issues. So let me just move forward with this question to Dr. Paul. Sir, how are urbanization, changing lifestyle, environmental factors, and workplace stress contributing to the growing burden of migraine across different populations?
So this is a very pertinent question. That in our practice, what we have seen, what WhatsApp have brought into our life. Let us see that. With the availability of WhatsApp, anybody can send us the report. We have to answer that report. So indirectly, his digitalization or his screen time has increased. So is the hours. So is the stress involved in answering that and managing the patient. So I think you are patently right that with though we are improved, we are doing so much with the technology, but at the same time we have to bear the cost also. Just like fire, if we don't, fire can help us in cooking up the things and it can also destroy our house. Similarly, we have now seen so many youngsters who have been using phone, or you can say their screen time is so much increased that they have brought everything to the halt. The life has become sedentary. It has increased the chances of weight gain, then obesity. Obesity itself a one of a trigger, or you can say for migraine also. Secondly, even stress, though stress can cause tension headache, but stress can lead to sleepless nights. If you have sleepless nights, then indirectly it sets up the vicious circle. Plus this you can say the fast adaptation in our life is also one of the most important factor, and sometimes we keep on neglecting our headache part, and we try to take the drugs from the over the counter drugs, so we have don't have the time of our busy schedule to go to a specialist doctor. So these all add up, and they will even add up to the burden of the migraine itself also.
Thank you so much, sir. Modern life really does seem to be playing its part here. Now, moving to Dr. Khanal. So, despite advances in migraine treatment, what healthcare delivery gaps continue to limit equitable access to quality care in Tier 2 and 3 and rural India?
So we know that migraine does not see any area. Okay, it happens even in the modern cities or in the rural area. But what we encounter in our clinical practice in the metro cities is only the tip of the iceberg. We see there is no, there is beneath the iceberg. There is a lot of patients. There are so many patients, and this happens because of severe shortage of specialists, limited primary care training, and high cost of advanced treatment. We are talking about CGRP, we are talking about specialized apps, we are talking about headache diaries, but we have to keep in mind that 90%, 95% of the population will not get all this access. So there is shortage of specialists, particularly in those areas. So second is the geographical mismatch. You will find that 70% of the Indian population, they reside in the rural areas, and the vast majority of them, neurologist, where you will get in the tier 1 and up to tier 2 cities, you may get metropolitan cities. But in small towns, they face a lot of problem. What will happen? They will have long travel time. They have financial burdens to consult a qualified doctor who is qualified to handle cases of migraine or headache. So in rural areas, there is dedicated neurological support system is not there, and that leads to a treatment delay and inappropriate referral also. Second is the primary care knowledge deficits. What we need to do is that the general practitioner and the local healthcare providers, they have minimal formal training about headache. For them, headache is a normal phenomenon. That is, normalization of headache is there. They do not know that migraine can be a headache plus. There can be other symptoms of migraine like nausea, vomiting, photophobia, phonophobia, unilateral throbbing, all those diagnostic criteria what we talk about the international criteria for headache. They do not know anything. So basic knowledge of migraine diagnosis or headache diagnosis is lacking. Plus the use of over the counter painkillers and non specific analgesics is very common, and this has resulted in high rates of medication overuse headache. The question was that, can migraine change over time? That question was raised. So what we have to keep in mind, one thing that is rising now is the medication overuse headache, the use of over the counter pills, and we get lot of patients of MOH in our clinical practice because of that. Affordability and supply constraints. Now we have talked about some newer therapies. Yes, that is available in tier 1 cities, in metro cities, but that lacks in the tier 2 and tier 3 cities, rural areas. Plus, it is very costly drug. So these costly drugs, they do not have any public or private insurance to get those drugs. Compliance is very much poor, even if you write those drugs. Can the patient procure the drug in the rural area? No. So the lower economic group, which is the main sufferer of migraine, 90% of them, until we get generics like we do in multiple sclerosis, now we have generic drugs. Lot of other conditions like oncological conditions, so we have generic drugs. Till those time, the lack of these newer medications will be there in the lower economic group. And so what will happen? They will favor more the cheaper painkillers, and the modern medicine will always be lacking in this tier 2 and tier 3. Plus the availability of medicines, they have to purchase the medicine from tier 1 cities or metro cities, so the pharmacies are also lacking that. The next point is the socio-cultural stigma. It is always considered migraine to be just because of an ordinary stress, sleep disturbance. No, so all these things keep the rural areas where the women are there. Mostly, they are the no, they are the sufferers of migraine. What we can do? How can we bridge the gap? We can bridge the gap by joining the tier 1 cities with the tier 2 or tier 3 cities to the help of telemedicine. When I was in PGI Chandigarh, we started those telemedicine programs where we used to go and answer the questions regarding migraine, stroke, all those things. So that can help in a way to at least join the thing. Second, training the primary care providers. These two things can bridge the gap. So primary care provider, whatever you're saying, if you can percolate that in the society, awareness programs through print media, through news media, plus if we can call those primary care GPs to our own institute, teach them the basic knowledge how to differentiate a primary headache from a secondary headache, this will help in a long way to eradicate migraine.
Thank you so much, sir. Access clearly remains one of our biggest challenges. Coming, coming back to you, Dr. Paul. So, considering its significant impact on quality of life and productivity, should migraine receive greater priority within India's public health and non-communicable disease agenda, and why?
Thank you. I think this is the ideal platform to answer that because it is a difficult question. So, if we see what are the things which can be included in any national program, one is they have rightly said that diabetes, even cardiovascular disorders, cancer disorders, because they do impact not a single person but the whole family. When the whole family is involved, even society is involved, then it has to be in the national program so that we can reduce the burden of the disease and also to reduce the impact of that disease on the society itself. But you yourself have said that there is so much of burden of migraine itself is there. Now, so many patients are there which may be diagnosed, which may be undiagnosed, which are in the urban area, so they are amenable to the healthcare system, so they are diagnosed. Whereas those in the rural area, so many times we have seen there is a gap of I think 1 or 2 years of diagnosing migraine. Actually, it was migraine which was being treated something else in the rural area. So this is a big gap is there. And if we see the second part, the migraine typically affects the young productive generation usually from 20 years to 30 years. So this is the generation which will have a which is economy driven, which is research driven, which are our you can say the support of any nation is the younger part. So if younger part is being disabled with any disorder, then it's going to indirectly impact your economy, impact your productivity, and even to your you can say the society also get impact indirectly, not directly like cancer or diabetes mellitus is there, but it do impact. Also what we have seen that everybody is now pointing out that we are facing problem of use of these narcotic drugs which are easily available. Whenever you get headache, you get any pain, you go to them, they give you the drug. So this has what has actually not helped us, it has actually plumbed into a addiction state in our society, which is now you can say very difficult to treat as also very difficult to handle also, because you are using this drug, you are becoming very aggressive, there are so many rages are there, so many crimes being conducted. So indirectly if we see, this is going to impact our society and affecting which is we are unable to see because we are focusing on one disease. Thirdly, these if we treat them, we may be improving the quality of life, specifically in the female. That rural part, as one of our esteemed speakers said, that rural are devoid of any primary health care. So what will happen? They will keep on suffering. The household will suffer. The children will be neglected. So indirectly, again, our workforce will be going to be affected. And now to implement this program is not a very, you can say, require a lot of money or lot of, you can say, resources. We have already asha workers, we have already trained healthcare worker. What they have to do, they have to survey, and just as Dr. Shankar said, there is a very short, you can say, a 2-minute questionnaire which will diagnose that this patient is having migraine or not, which is, even I think 2 minutes is, I have said more, it may be in 1 minute only. You have to administer that question to a through your asha worker or healthcare worker which are posted in the rural. No need of any economical, you can say, burden on us. So we can screen them, and if there is some red flag, try to send them. And these type of disorders even can be managed by a primary physician also. They don't need an expert unless there is a refractory medication overuse, or you think you are unclear whether it is actually a migraine or something else. So we are required. But this, as our one of said, that telemedicine also. But these healthcare workers at least can screen them, can educate them, can start the meditation part, yoga part, or behavior part. Or even I think in my practice, what I have seen, if you reassure a patient that you have nothing else in the brain, it is just a migraine, 50% of them get relieved. So just reassuring the our rural population that this is nothing else, don't worry, don't panic. So this will reduce the burden of migraine by 50% without. This is called placebo effect. Na? So even without medication, you are able to treat that. So I think it is high time that we should be more aware. We should not consider it is a vascular headache because it has long-term consequences. Forget about the advanced treatment, but we basically, if we do basic thing also, it will help a lot in the society, and it will improve the outcome, quality of life, our productivity, and even the economics will be better enough. Thank you. Thank you.
Thank you so much, sir. That's really a compelling case for migraine to be taken far more seriously at a policy level. Now, ending this round, coming to you, Dr. Singh, to close out our thematic discussion this evening, if you could recommend one policy or healthcare initiative to improve migraine awareness, early diagnosis, and access to specialized care in India, what would it be?
So yeah, so it's the with the most important question, and you are also the part of the answer. I think the one, if you say one policy, I would say digital awareness. Okay, so as with this platform, we will make people aware. So now everybody has a mobile and they have apps. So if we somehow spread this digital awareness through the some apps, or by way of advertisements, or anyway, as your programs are also there, and if they reach to the rural as well as every nook and corner of the country, then people will know that they what they are having, and they will stop taking self medication. They will think of all these other measures, like relieving their headaches by modifying their lifestyle, knowing about their triggers, relieving their stress, improving their dietary habits, improving their sleep patterns. So digital awareness, and other thing is digital availability of the specialists by way of modern ways of communication, as Dr. Manoj has told, telemedicine. And we can devise some special apps for migraine patient where they can place their symptoms and problems, and they will be able to know the diagnosis, and they can connect to the specialist, and therefore they will have a early diagnosis. They will not rely on self medication. They will not take the medication that need not to be taken. And thereafter they may get prescriptions also digitally, so they can take medication. So this digital awareness part is very important, and in this I would stress on that the patient have their records saved digitally, and whenever and wherever they are required, the patient may visit personally and have these records. And in this way they can know about their headaches, frequency headache diary can also be incorporated in this way in the digital form. So I think this is one policy which can change the scope of migraine management, the landscape of migraine management, and it need to be involving the healthcare policymakers as well as doctors and people like you who are propagating about the migraine awareness. And in my view, I think digital India is actually not possible till we incorporate these digital technologies in medical sciences. And migraine is one of that field where we desperately need digital awareness. Thank you.
Thank you so much, Dr. Singh. It's a fitting note to end our thematic round on and real actionable change at the policy level. That brings us to the end of what has truly been an insightful and important conversation. Before we sign off, first I would like any one of you to, if you have anything to say in your native language to the audience so that they can feel connected.
So I can say in Hindi. So I'm in Mohali. I cater Himachal Pradesh, Haryana, Punjab as well. So most of the people know about this Hindi. So मैं बोलूँगा कि माइग्रेन को हल्के में ना लें. कोई भी सिरदर्द नॉर्मल नहीं होता. अगर किसी को सिरदर्द हो रहा है तो कुछ डिजीज है. वो माइग्रेन का हो सकता है, वो टेंशन टाइप का हेडेक हो सकता है, वो साइनस का हेडेक हो सकता है, वो सर्वाइकल का हेडेक हो सकता है. उसको क्लासिफाई करना है, उसका इलाज लेना है. शायद वो दवा की जरूरत ना हो पेशेंट को और सिर्फ कुछ मेथड से ही वो ठीक हो जाए, और पेशेंट को अगर हम रीअश्योर कर लेंगे तो ही ठीक हो जाएगा. और कई बार होता है कि सेल्फ मेडिकेशन से पेशेंट की दिक्कतें बढ़ती है, तो इलाज के लिए अगर हो सके तो स्पेशलिस्ट के पास जाए जिससे समय पे इलाज हो सके. जैसे सर ने भी बोला था कि एपिसोडिक हेडेक क्रॉनिक में कन्वर्ट हो जाता है अगर हम मेडिसिन बहुत ले रहे हैं और उसको समय पे ध्यान नहीं दे रहे हैं. जहां पे हम बचाव के लिए मेडिसिन स्टार्ट कर सकते हैं, दवाएं दे सकते हैं, और मरीज शायद उस बीमारी को उस लिमिट तक, उस सीरियस लिमिट तक आने से बच सके. तो मेरी यही मैसेज है कि माइग्रेन को हल्के में ना लें और माइग्रेन का उचित समय पे उचित जगह पे इलाज करें. थैंक यू.
Thank you so much, sir. Thank you so much, sir. So I would take this opportunity to take a moment to sincerely thank our panel. I'm so sorry. So, Dr. Paul, do you want to say anything, sir?
ਜਸਟ ਮੈਂ ਕਹਿਣਾ ਚਾਹੁੰਦਾ ਸੀ ਪੰਜਾਬੀ ਦੇ ਵਿੱਚ ਵੀ ਕਈ ਵਾਰ ਅਸੀਂ ਕਹਿੰਦੇ ਆ ਡਾਕਟਰ ਸਾਹਿਬ ਕੋਲ ਕੀ ਜਾਣਾ, ਦਵਾਈ ਨਾਲ ਠੀਕ ਤਾਂ ਹੁੰਦਾ ਨਹੀਂ, ਮੈਨੂੰ ਬਾਰ-ਬਾਰ ਦਵਾਈ ਲੈਣੀ ਪੈਂਦੀ ਹੈ. ਬਟ ਇਹ ਗੱਲ ਨਾ ਸੋਚੋ ਵੀ ਦਵਾਈ ਲੈ ਕੇ ਨਹੀਂ ਠੀਕ ਹੁੰਦਾ. ਹੋ ਸਕਦਾ ਦਵਾਈ ਨਾਲ ਆਪਾਂ ਉਸ ਦੀ ਵਧਣ ਦੀ ਜਿਹੜੀ ਸ਼ਮਤਾ ਹੈ, ਪਲੱਸ ਹੋਰ ਜਿਹੜੀ ਦਵਾਈਆਂ ਅਸੀਂ ਲੈ ਕੇ ਆਪਣੀ ਕਿਡਨੀ ਖਰਾਬ ਕਰਦੇ ਹਾਂ, ਕਈ ਵਾਰ ਸਾਨੂੰ ਪੇਟ 'ਚ ਅਲਸਰ ਹੋ ਜਾਂਦੇ ਹੈ, ਬਲੀਡਿੰਗ ਹੋ ਸਕਦੀ ਹੈ, ਉਹਦੇ ਨੁਕਸਾਨ ਸਾਨੂੰ ਜ਼ਿਆਦਾ ਹੋਏਗਾ. ਮਾਈਗ੍ਰੇਨ ਦਾ ਨੁਕਸਾਨ ਸ਼ਾਇਦ ਇੰਨਾ ਨਾ ਹੋਵੇ ਜਿਹੜਾ ਮਾਈਗ੍ਰੇਨ ਦਾ ਟ੍ਰੀਟਮੈਂਟ ਨਾ ਕਰਾ ਕੇ ਸਾਨੂੰ ਹੋਣ ਵਾਲਾ ਹੈ. ਕਈ ਵਾਰ ਅਸੀਂ ਬੜੀ ਵਾਰ ਦੇਖਦੇ ਹਾਂ ਬਟ 2% of the person the reason of kidney damage is not diabetes, is not hypertension, but it is the medication overuse. So this is the message. Please now, as we are moving, as said, the digital India, so let it be a so advancement that we forget to take medicine from this over the मतलब दुकान तो दवाइयां ना लइए, दवाइयां लेनी है तो एक किसी क्वालिफाइड बंदे तो सलाह करके लइए. थैंक यू.
Thank you so much, sir. So before we sign off, I want to take a moment to sincerely thank our panel, Dr. Praveen Gupta, Dr. Manoj Khanal, Dr. Birinder Singh Paul, and Dr. Amit Shankar Singh for so generously sharing your time, expertise, and clinical insights with us this evening. We have covered a tremendous amount of ground today, from recognizing the true impact migraine has on patients' life, to the science redefining how we diagnose and treat it, to empowering patients as partners in their own care, and finally to the policy shifts needed to make quality migraine care accessible to everyone in India. I'd also like to thank Once again, I'm Neil Healthcare for powering this important conversation and the entire Voice of Healthcare team for making this session possible. And thank you to everyone who joined us live this evening. Your time and attention mean a great deal to us. Please do share your thoughts, questions, and comments below. We'd love to hear from you, and this is a conversation we hope continues well beyond today. On behalf of the entire panel and Voice of Healthcare team, thank you so much, everyone, and have a good evening.
Thank you.
Thank
Thank
you.
you so much.
Thank you.
Thank you, everyone.
Thank you so much.